Hello everyone, this is Dr. Madhusudan Rao on the program I Teach Medical Students. The topic of the day is cerebral malaria, its pathophysiology. The students, undergraduates as well as the postgraduates of medicine are expected to know the pathophysiology of cerebral malaria, as this is the most dangerous complication of falciparum infection. We consider the complications of falciparum infection. Cerebral malaria is a dreadful complication which accounts for nearly 2 million cases with 450,000 deaths annually. It's not simple. Severe malaria is predominantly caused by P. falciparum. Nearly 13% of the falciparum infections account for cerebral malaria. This particular condition is a medical emergency. Pathogens of its manifestations: neurological injury, sequelae, are complex and multifactorial. If the patient is left untreated, it leads to death. The clinical diagnosis of cerebral malaria is based on presentation with altered sensorium, with the demonstration of asexual forms of P. falciparum in the peripheral smear, in the absence of other causes of coma. That means when you encounter a patient with altered sensorium, you demonstrate asexual forms of P. falciparum in the blood smear, and there is no other demonstrable cause for coma in that particular patient, then you are dealing with a case of cerebral malaria. So you have to consider this particular condition as a medical emergency and treat the patient effectively in order to avoid the sequelae and death. Now let us proceed to understand the pathophysiology of cerebral malaria. Neuropathy in cerebral malaria is complex and it is multifactorial, which is not fully understood. What are these factors? Number one is obstruction to microcirculation. Number two, endothelial dysfunction. Number three, metabolic disturbances. And four, inflammatory response. These are supposed to be the factors involved in the pathophysiology of cerebral malaria. Obstruction to microcirculation. How it is brought about? What are the consequences? Obstruction to the microcirculation is brought about by sequestration of the infected RBC in the microcirculation, in the capillaries and postcapillary venules. How it is brought about? There is increased cytoadherence. That is, infected RBC, they hug to each other. They also hug the normal cellular elements in the blood. They adhere to the normal RBC. They adhere to the endothelial lining of the capillaries and brought about the havoc. So how it occurs? So infected RBC, they express a foreign antigen on the surface of the membrane. It's called PFEMP1. They also express histidine-rich protein on their surface. With these foreign molecules, they bind to the receptors expressed on the surface of the endothelial cells, that is CD4. Binding of the infected RBC onto the endothelial cells bring about inflammatory response and the consequences. Then platelets also cause clumping of the red blood cells. So platelet-related clumping of the RBC also adds to the blocking of the microcirculation. And infected RBC have reduced capacity of lymph mobility. So they flow sluggishly in the microcirculation, thereby causing obstruction and the consequences. By and large, the amount of sequestration is related to severity of cerebral malaria. So that is excessive sequestration or extensive sequestration in the microcirculation is associated with more severity of the cerebral malaria. This is what happens in the microcirculation. The mechanism of obstruction of the microcirculation in the cerebral malaria. So if you take the RBC of the patient with hemoglobinopathies, the distribution of this antigen is rather abnormal on the surface of the RBCs with abnormal hemoglobin. And the degree of cytoadherence is poor in patients with hemoglobinopathies. That's why persons with the hemoglobinopathies are less prone for complication of falciparum infection. That's how it can be explained. Yeah, because most of the time they said, and we see the patients with hemoglobinopathies are less prone for complication of falciparum malaria. The next one is the inflammatory response. So how the inflammatory response is brought about? The binding of the infected RBC with the receptors on the endothelium triggers inflammatory response. What is the inflammatory response? Results in release of TNF alpha and interleukin 6. This further perpetuates endothelial injury. Once the endothelium is injured, there is activation of the coagulation mechanism and formation of the microthrombi, which in turn results in the obstruction of the microcirculation, subsequently leads to hypoxia, nerve cell membrane dysfunction, and cytotoxic cerebral edema. This is what happens following the obstruction to microcirculation. And there is disruption of the blood-brain barrier, which in turn leads to cerebral edema and raised intracranial tension. You, my dear students, should remember one thing. Endothelial lining of the capillaries is anticoagulant. Subendothelium is coagulant. What do you mean by that? Endothelial lining has got the protective mechanism to avoid activation of coagulation mechanism. Once it is disrupted, there is exposure of the subendothelium which promotes coagulation. Intravascular coagulation results in formation of the microthrombi, obstruction to the microcirculation, and the consequences. Because of the integrity of the endothelial lining of the blood vessels, blood is maintained in fluidity. Okay, so once there is injury to the endothelial lining, it leads to the consequences of intravascular coagulation and formation of microthrombi, leading to obstruction, hypoxia, further injury to the endothelium, cytotoxic edema. So, the consequences of these factors. So, as I told you, there is endothelial dysfunction. Once there is injury to the endothelium, there is activation and activation of van Willebrand factor, angiopoietin, TNF alpha, soluble endothelial receptors are exposed and activated, nitric oxide turnover, decrease the levels of L-arginine with depletion of the levels of nitric oxide. Okay. So once the van Willebrand factor is activated, as you know, it induces procoagulants activation and local microthrombi formation, which further leads to the obstruction, hypoxia, injury, etc. There is angiopoietin 1 and angiopoietin 2. Angiopoietin 1 stabilizes endothelium, regulates nitric oxide normally. Whereas angiopoietin 2 antagonizes angiopoietin 1, increases vascular permeability in response to inflammatory stimuli, upregulates response of endothelial receptors, endothelial growth factors, and the consequences. This is how the endothelial dysfunction following its injury leads to the consequences of micro circulation, blocking of the microcirculation and its consequences. Next factor is metabolic disturbances. What are they? Hypoxia, hypoglycemia, hyperammonemia. Hyperammonemia is one of the important metabolic disturbances that you have got to consider in the pathophysiology of cerebral malaria. Hypoxia resulting from the obstruction to the microcirculation, as I told you. Everybody knows once there is obstruction to the microcirculation, there is ischemia and hypoxic injury to the tissues. Release of oxygen radicals, consumption of arginine, diminished nitric oxide levels, lactic acidosis, due to anaerobic glycolysis, injury to astrocytes, membrane dysfunction, edema, and resonant intracranial tension. This is how the vicious cycle continues and perpetuates the injury to the tissues. Okay. Remember, nitric oxide is the most important circulating vasodilator. Once it is depleted, there is vasoconstriction, and hypoxia, hypoxic injury, and the consequences. Hypoglycemia, as I told you, is one of the complications of severe malaria, as you know. Depleted nerve cells of adequate energy, uh, they cannot generate ATP. So ATP dependent sodium potassium pump mechanism is disturbed, thereby causing cellular injury. Hypoglycemia is compounded by hypoxia, results in lactic acidosis, membrane dysfunction, edema, intracranial hypertension, and altered sensorium, which leads to seizures and coma. These are the consequences of hypoglycemia. Next important factor is hyperammonemia in the metabolic factors. This is one of the important factors responsible for high mortality in cerebral malaria. How it is brought about? Infected RBC metabolize hemoglobin that leads to release of glutamine into the cell. Deamidation of glutamine produces ammonia. Ammonia is released out of the RBC. This is taken by the astrocytes and converted to glutamine. This is how the recycling of the glutamine occurs. This leads to oxidative stress of the nerve cells. So in course of time, there is increase in the brain glutamine levels, which continues to getting recycling between astrocyte and RBC. So excessive levels of glutamine, which is an excitatory transmitter, induces seizures. So there is gradual accumulation of the ammonia in the brain when the load of glutamine is more than the capacity to be cleared. That is, when the load of glutamine is increasing, the ammonia levels increases beyond the level of the clearance by the cells. That leads to encephalopathy. If the patient is simultaneously suffering from liver injury, this again contributes to metabolic encephalopathy. Well, this is in brief about the pathophysiology of cerebral malaria. Well, I think you could follow the topic. I expect you have noted the important points, and this would help in your presentation in the examination when asked. And thank you very much for patient listening. And we'll meet again in the next class. Until that time, bye bye and thank you. If you like my video, please subscribe to my channel. And thank you very much. Until the next class, bye bye.